Welcome, and those of you who have logged in. I'm just giving it a few seconds here just to make sure people are able to log in okay here. I think I'm going to get started in the interest of time while people are continuing to pour in here. Hello, good afternoon. This is the Seizure Smart School Personnel webinar provided by the Epilepsy Foundation of Minnesota. Before we get into the content here, I do want to go over some housekeeping items. This is going to be an hour-long webinar. And then as far as bandwidth goes, if you have any applications in the background, such as like Pandora or YouTube, pretty much those video applications and those music ones, you may want to have that shut down. I've even been told that having your email up in the background can affect the way that this webinar runs, and we do have video clips in this webinar, so I recommend that you have those shut down. This webinar does qualify for a certificate of completion, and that will be sent to you in a follow-up email within a week or so. This webinar is also being recorded, and if you want a recording that's edited of this, you can email me or somebody else in this presentation. Our contact information is throughout the webinar. And then a quick disclaimer. The information shared in this webinar is to inform you of the aspects of epilepsy. However, all potential treatment options should be discussed with your medical provider. We also have the chat disabled, but you can use the question and answers area if you do have any questions throughout the webinar. I do recommend that you put them in whenever you have them. I won't be taking questions until the end, but it's a good way to remember to do it. If you do have any tech issues during the webinar, please feel free to use the question and answers area, but we don't have any tech capabilities on our end, so unfortunately you will probably have to contact Zoom. Something that I've been able to troubleshoot in the past is logging off and logging back on if I'm having any issues, but anything beyond that you may want to contact Zoom. My name is Jamila Pickett. I'm the Senior Coordinator of Education at the Epilepsy Foundation of Minnesota. My primary duties are to provide educational programming throughout Minnesota and Eastern North Dakota. You can contact me at my email. It is jpickett@efmn.org, or you can call me at 651-287-2315. And I'm going to send this to my guest speaker, or my co-presenter for today.
Thanks, Jamila. My name is Amy Haugen, and I'm the Regional Program Manager at the Epilepsy Foundation of Minnesota. My responsibilities include managing the staff and programming in Greater Minnesota in the 4 outstate regions. We provide programs and services throughout the state of Minnesota, and then I also focus on the West Central Minnesota counties. You can reach me at my email at amy.haugen, Haugen, @efmn.org, or phone number is 320-203-9722.
All right, so today's objectives are going to be defining epilepsy and seizures, identifying the 4 leading types of seizures, learning the appropriate responses to these seizures, increasing knowledge of available treatment outcomes, and then gaining information about supporting students with epilepsy and seizures. All right, before we get into the content, we're going to do a quick poll. So I'm going to be launching a poll here. And it is, have you ever attended an EFMN webinar? So yes, no, and I have in the past, but not for a while. And I'll give people some time here to answer those questions. Looks like a few more people may need to put in their answer here, so I'll just give it a few more seconds to let these last few people enter in their information. All right, I am going to end the poll now. And so it looks like a majority of you have attended an EFMN webinar, so welcome back. And for the new people here, welcome. I'm glad to see you here today. All right. So to get started today, we're just going to go over some facts about epilepsy. So epilepsy is a condition that we have known about for centuries. There's a lot of documentation that talks about epilepsy and seizures, and there are a lot of facts that we still don't even know today. So there are things that we're still trying to figure out about epilepsy, and there are things that we were able to debunk in the past. So epilepsy is not a contagious condition. It's not like a flu or a cold. You can't catch it. Epilepsy is not a mental health illness, but there are many people with epilepsy that do have mental illness, and that's very common. Epilepsy exists on a spectrum, and that can mean a lot of things to a lot of different people. For some people, maybe they are new to epilepsy and they're still trying to figure out their medication regimen, and maybe they're having more seizures, whereas maybe somebody is on a really good medication regimen or treatment option and they're not having as many seizures. And then the last one is that people rarely die from having seizures. So what is epilepsy? Epilepsy is a neurological condition that causes reoccurring seizures. The key for it to be epilepsy is it does have to come from the person's brain, and it has to happen more than once in a person's lifetime. It also has to do with the electricity in a person's brain. So on your screen here, you see kind of blue lines kind of lighting up throughout this brain. And that's just to show that that's that electricity kind of traveling throughout the day. The reason why there are things that qualify as epilepsy is because anybody can have a seizure, and epilepsy is not the only seizure condition. So these are the things that make up epilepsy. Some people may call their epilepsy seizure disorder or condition, but just because somebody has a seizure disorder or a seizure condition does not mean that they have epilepsy. There are a lot of other seizure conditions as well. I always like to use whatever language that person is using themselves or whatever language they prefer to make sure that I'm using the correct terminology and what they feel most comfortable with. Epilepsy is a very prevalent condition as well. So according to the World Health Organization, about 50 million people across the globe have epilepsy. And according to the Centers of Disease Control, 1.2% of the US population has epilepsy. And this is 470,000 children and nearly 1 million people over the age of 100, or nearly 1 million people over the age of 55. 1 in 26 people will develop epilepsy at some point in their lifetime, and the statistic comes from epilepsy.com. So 60% of epilepsy cases have an unknown cause, but of the known causes, head trauma or brain injury is the #1 known cause. And a good rule of thumb is anything that can cause injury to a person's head or brain can cause epilepsy. So we have some examples of leading causes of epilepsy here, but it would be impossible to list every single cause here. But there are a lot of things that do relate to that head injury. But there are other things as well as such as genetics or other things that can cause epilepsy as well. So this is definitely just a limited list. So when we're talking about what epilepsy is, we want to talk about what seizures are as well. Seizures are the symptom of epilepsy. What you see on your screen here is a brain, and this brain is kind of having different parts lighting up. These different parts are in charge of different functions in our body. Throughout these different parts, we have what are called pathways, and on these pathways are the electrical signals that I talked about earlier. These electrical signals are called neurons. What can happen throughout the day is when your brain is working normally is that these electrical signals work with the pathways and part of your brain to kind of tell us what to do throughout the day. So if we're eating or drinking or whatever we're doing. What happens though when somebody's having a seizure associated with epilepsy is these neurons can get sent when they're not supposed to. That's called a misfiring, and that's what can change a person's awareness, sensation, or movement. And that's the seizure being visualized in that person. Depending on what part of the brain is being affected by that misfiring activity, that's what the seizure is going to look like. So for example, I see that the occipital lobe keeps kind of lighting up on this image. That's the part of the brain that deals with things like eyesight. If somebody's having a misfiring in this part of their brain, then perhaps their seizure looks like seeing something that's not necessarily there. Maybe this entire brain is being affected by misfiring, and this person may have entire body convulsions. Another important topic to think about are seizure triggers, especially when we're thinking about a school setting. So a seizure trigger is sometimes hard to describe because it's something or some stimulus or something in a person's environment that can cause them to have that misfiring in their brain. And for some seizure triggers, it happens right away where somebody is exposed to this trigger and they have the seizure right away, or with other seizure triggers they kind of have to build on each other, and then a person is pushed past their threshold or kind of pushed over the edge, and then they have a seizure. So this is another one of those lists that it would be impossible to actually create a list for. There are so many seizure triggers out there. If you went on a search engine right now and Googled seizure triggers, you'll probably find a list 10 times bigger than this one. But there are a few seizure triggers that I do like to go into depth about. The first one is stress and anxiety. So this is the #1 seizure trigger outside of missed or late medication. This trigger is not very tangible because stress can mean a lot of different things to a lot of different people. But in general, there are times of year that are more stressful than others when you're thinking about a school setting. There's no data that talks about lowering your stress as being a way to stop this trigger. But if you avoid this trigger in the first place, it can be helpful. So being prepared for things like standardized tests or being prepared for a project can lower someone's stress or completely prevent it. We also can't control those little stressors in the day sometimes. So having times in the day where a person can practice mindfulness can be helpful, because these types of practices can make it easier for them to cope when they do have those stressors. Lack of sleep and fatigue is another trigger that's common in children, but this may be true in adults as well. It's not just fatigue that can cause somebody to have a seizure if this is their trigger, but for some people, their trigger is sleep time. So around the time that they usually wake up or around the time that they usually go to sleep, they may have increased seizure activity. And for the rest of the day, they may have little or no seizure activity at all. And then the last trigger that I like to go in depth about is photosensitivity. So that's commonly thought of as flashing lights or strobe lights. So photosensitivity is not always going to be the flashing lights and strobe lights. Sometimes it's regular fluorescent light or light from the sun. But with this one, it's in a school setting. I think the question I mostly get asked about is fire alarms. So this is a rare trigger, but if you know of a child that has this trigger, you can confirm with your school to see if their fire alarm is set as 2 hertz, and it also has breaks periodically between the light flashing, and that can reduce that trigger for somebody. Just because somebody has one trigger does not mean that they have more than one, and not every single seizure is associated to a trigger. And I say that because we do want to be careful about making false associations. All right, so I am going to go to the next slide here and pass it to Amy.
Thanks, Jamila. We're going to dive right in now to the types of seizures and the classifications for seizures. Many of you may have heard the terms grand mal and petit mal. In the past, those were the oldest terms that were used to describe the 2 different classifications of seizures at that time. But the CDC and the International League Against Epilepsy renamed the sort of bigger buckets or classifications because those first two terms didn't tell you much about the actual location of the seizures or where they were originating from. So what you see here is there's three different classifications of seizures now: focal, generalized, and unknown. You may be familiar with the terms partial and generalized, but we also have this unknown onset bucket now. And so when we talk about these three types, it's really about where in the brain does the seizure start. A focal onset means there's a focus to that spot. It's coming from one part of the brain in particular that can be sort of pinpointed on EEG testing. If we talk about generalized seizures, those are the types of seizures where their whole brain is seizing. It is both hemispheres are involved. It might be the misfiring is going back and forth across the neural pathways on both sides of the brain. And then we have this unknown onset, which is a little bit newer since 2017. You can see these are the newest classifications. And the unknown onset oftentimes happens when a person is in the beginning stages of being diagnosed because maybe they haven't had scans or an EEG or have had the opportunity for the doctor to really figure out where the onset is coming from. And so they'll oftentimes be put into this unknown category, and sometimes they're left in that unknown category if they the doctors are having a hard time figuring out if it is a focal onset or a generalized onset. Next slide. We do know there are over 40 types of seizures, but we're going to focus on 4 seizure types today. 40 is a lot of seizure types, and majority of those probably you maybe have not heard of, and they're more uncommon. But the 4 we're going to talk about are the 4 most common ones you would probably see in a student or even in your life in general when you're out and about. There are 2 focal ones we'll talk about, and then 2 generalized seizures. The first focal one is called a focal aware seizure. This is the type of seizure that the person does not lose their consciousness. There's not an altered state of consciousness, and so they're aware of what is happening to them. In the past, this was called a simple partial seizure. So if you're familiar with that term, that the new terminology is focal aware. There's a couple of ways that this one can manifest. There's a sensory type of focal aware seizure where it's something is being impacted in their sensory lobe of their brain. And so maybe they're hearing something or they taste something funny, or like Jamila was saying, maybe it's coming from the portion of their brain where their vision is. And so they see maybe a flashing light or a different color light, all those kinds of different sensory types of things. There might be some motor involvement if they are having this type of seizure where there is maybe one part of their body that twitches or moves rhythmically. Or there can be this type of seizure where they have an overall sort of mood change or a feeling, not like a mood change for a long period of time, but maybe they all of a sudden feel really uneasy, or they might even feel like they're afraid. Something just doesn't feel quite right. Another thing to keep in mind with this type that I know I've learned from people is sometimes even it's just a sensation, a change in temperature. So if they're suddenly hot or they're suddenly really cold, those can be other sorts of examples. They typically don't last more than a minute or two. And again, because they don't have a loss of consciousness with this one, really what you want to make sure that you are doing as the responder is providing that emotional support for them. And then as always, you'll hear me say this throughout, documenting what you are actually observing. What were you seeing happen for the student, or what was the student reporting to you that they were experiencing? So that's the focal aware seizure. Next slide. Now we're going to talk about the focal impaired aware. This is the most common seizure type. Oftentimes it's not mistaken for some other things that we'll talk about in a bit, but focal impaired aware basically means that it's a focus, there's a focus to where the seizure starts. Maybe it's one part of their brain, and their consciousness level is altered. They're not unconscious, so they have that basic level where they can, they have their 5 senses about them. They can hear, see, smell, taste, things like that. But the impaired level is where they they will not be able to respond appropriately to direction. They might respond to their name. So if you were to say their name, they might turn towards you. But if you ask them a question, probably not going to get an appropriate response, or may not even get a response at all. This used to be called a complex partial seizure. So if you've heard that terminology, that's where this one was before the change. You might see a couple of different things happen. There might be some repetitive movement. Picking at their clothing might happen. They might stare off, or they might chew, chewing motion with their lips. They might speak differently in that it's garbled, or it's you can't tell what they're saying. And one of the key things with this one is they do have what we call fight or flight response still. And so there is a chance that they might become agitated if they're restrained. This one doesn't typically last 1 to 3 minutes as well, and oftentimes what it's confused with is other behavioral issues. So a student might have this type of seizure, and especially if they become agitated if they're touched, it might seem like they are oppositional defiant, or that they just have some different behavioral issues going on. In older kids and young adults and adults, oftentimes it's mistaken for things like intoxication or being high on a substance, or even for some different mental health concerns. So this one is the most common. I'm gonna show you a video clip here of a man, an adult man, having one of these seizures in the mall. So we'll go ahead and go to that clip. All right, so you might have noticed a couple of different things in that video. You noticed that he dropped the 2 bags that he was carrying, and it stared off, and there was some shaking and it was some rhythmic sort of moving, but it didn't have a whole lot of purpose to it, right? And the responders in that one, truly, it shows how we really do recommend that you respond to it. I'll have you go to the next slide, and we'll talk about the response in that. What you want to do is, of course, take into account the individual and the situation at hand, where they're at, and how to best keep yourself and them safe. Always want to remain calm during this type of seizure, and track the time. Tracking time is really important with any seizure type, and we will talk a little bit more in depth about that when we get to the generalized seizures. But tracking time really allows you the opportunity to see how long is this happening, and to know, when should I call for help, medical help, 911. And so tracking the time is really important with this type as well. You want to guide them away if you can from any hazards, and stay with them until they've gained awareness. And as you watched that video, you saw that the security guard and the man that was responding, they didn't get super close to him. They allowed him to continue to go through his seizure actions that he was having, and that's really key, because you don't want to restrain them because of that fight or flight response that can kick in and lead them to becoming what would appear to be aggressive. The key thing to remember in this whole seizure type is they are not aware of what they're doing. So when a person having this type of seizure comes out of the seizure, they won't have, for the majority of people having this type, they won't have any recollection of what has happened during the seizure, or even if they became aggressive or were trying to protect themselves, if they hit someone, pulled someone's hair, any of that kind of thing, they won't remember it. So when you're talking about students that have this type of a seizure, it's really important to reassure them that they're okay, that yes, they had a seizure, and really to reassure them that they're not in trouble, and that they're going to return that back to their baseline very, very, in a very short period of time. So that's the focal impaired aware and how we should respond. Next slide. We're going to move into talking about the generalized seizure types. There are a number of these, but there are 2 that are very common. One is called the absence seizure, and one is called the generalized tonic-clonic. Remember that the generalized seizure type means their entire brain is seizing, and so both hemispheres are involved, and with that comes a loss of consciousness. And so in the absence seizure type, it used to be called a petit mal seizure, and these can be very brief, just a few seconds typically in in length, but it's a loss of consciousness and a brief lapse of awareness. And so a lot of times what it looks like is they're just staring off into space. They're daydreaming. And what you'll see with this type is that oftentimes it'll mean they'll turn their head to one side or the other. You might see their eyes flutter or blink really quickly. But what happens with this one that's different is when they come back to awareness, there doesn't tend to be a ton of confusion as to where they are, what did they do. They return to their baseline pretty quickly. And so again, it's a shorter seizure, 5 to 20 seconds is typical. And oftentimes we know that you as school staff are actually going to be some of the first people that might notice a pattern to these. So let's say you have a student that has not been diagnosed, and you have the student, and within maybe the first few months, you notice on a pretty regular basis the same types of things happening. They stare off to one side, their eyes are fluttering, it lasts 10 seconds, they come back, they're fine. And you document this, and you realize that this is happening, repetitively, maybe a few times in a day, maybe a few times in a week. Oftentimes school staff are with students for the most concentrated period of time, right? Maybe not right now in the different ways that we're doing school, but oftentimes you might be noticing these changes in behaviors, and that's key to pass along what you're noticing to the parents. We've had lots of teachers say, yeah, we realized this, we were documenting it, we told the parents, they took their child to the doctor, and there they were diagnosed with absence seizures. So keep that in mind as a school staff. Your observations are really key. Next slide. I'm going to have you go back, Jamila, sorry. I forgot that we had to show you a clip of this. So we're going to show you a very brief clip. Watch this young girl as she's having this conversation. There's a few things to notice. She repeats herself, her eyes start to flutter, and then she'll go into the seizure.
This girl has absence seizures, and you will see her have one while she's talking.
Because he can be as heavy as ever.
And there's a real blankness, a vacant look in the eye, and then all of a sudden they're right back with you and able to engage.
Oh, pardon?
So she pretty quickly came back. She said, oh, pardon. Like she realized in that seizure, or in that time frame, that she probably had missed a few words that were being said while she was having the seizure. So they might ask you to, can you repeat what you just said? Or they might even ask their neighbor next to them, what did the teacher just say? Because they realize they've missed a few words in that time frame that they're having the seizure. We're going to move on to talking about the generalized tonic-clonic seizure. This is the one that many people think of as the most common seizure type, although it is not. It used to be called a grand mal, and oftentimes we still hear people call it that. But this type of seizure is not the most common, but the way I like to describe it is, if you've ever seen this type of seizure, it is memorable in that if you've seen one or had to respond to one, you remember what it looked like, and it makes an impression on you. So there's some things to think about when this type of seizure happens. There's a general progression to the seizure. And we like to share that with you so you know, actually, if you do have a student that has one of these, you know that this is a typical progression. And so what happens generally is, as they become unconscious, there'll be a hoarse sort of cry. It sounds like they are losing their voice. It sounds like they can't breathe maybe, but it's really just that force of air through their lungs and out of their mouth that causes them to cry out. They will lose consciousness. And so oftentimes if they're walking, it might be sudden, or they might sort of crumple to the ground. They'll lose consciousness, fall, and then what happens is they enter this tonic phase where their body begins to stiffen. And that'll happen for a second or two before they begin to actually convulse in the clonic phase. And what can happen in the beginning of this is oftentimes they might hold their breath just for a few seconds as this starts, and then they'll start breathing again. And oftentimes their breathing can be less frequent or more shallow. That can lead to their fingertips, their lips, their cheeks becoming discolored, which can be one of the more frightening things as a responder to see. It's typical to think, oh my gosh, they're not breathing, when if you get down near them and you can see that there is a breathing pattern, know that those discolorations are not uncommon. You might also see as they go into this seizure, as they crumple to the ground, you might see that their eyes get really big, or they roll as well. This one typically lasts 1 to 3 minutes. That might seem like a really long time, 3 minutes, but it is not an uncommon length for this one. The biggest side effects afterwards is that they will be tired and might be confused. Their whole body might be sore for a while, depending on what has happened during the seizure, and headache is another side effect of this type of seizure. We're going to show you a clip of a little girl having this type of seizure, and I want you to pay attention not just to the tonic and clonic portions, which we just talked about, but what else you're seeing during this seizure, and then we'll talk about it after.
They affect the whole brain and the entire body. The tonic phase is the stiffening of the muscles. Then the jerking movements begin, the clonic activity that you see here. A tonic-clonic seizure rarely lasts more than a few minutes. A person having one isn't conscious and won't remember what happened. The skin may become pale. Breathing may seem shallow or labored. Sometimes a child may lose bladder or bowel control or vomit as the seizure ends. These seizures may look painful or even life-threatening.
So a couple different things to point out in this. When we talk about response, I'll talk about the fact that she's on her side with a pillow under her head, but there's a couple things. There's always going to be a vocalization. That's a question we get asked a lot, is what is the up with how they sound? And really it's just that their vocal cords, don't lose their ability to vibrate and make noise. And so however their body is convulsing, there's going to be a sound to it as well. You probably noticed there was a whole lot of extra saliva that was produced. That's a very common response when the body is going through this type of seizure. It can look like it's foam. It can look like just a stream of saliva. That's very common to see as well. And then, like I said, her eyes, oftentimes their eyes will get really big, or they might even start to roll towards the back. And that is really common as well. I've had people say it looks like they're staring at me like they want me to help them. And they're not conscious. So really it's just the natural thing that their eyes will do is just remain open really big or roll a little bit. So let's go to the next slide and we'll talk about what are the steps for responding. Again, the first step that we want to mention is timing the seizure is super important. How do you know when it starts and how do you know when it ends? The seizure starts as they fall and cry out. You can go ahead and start timing, and it ends. I don't know if you noticed with this little girl, but everything went very limp and still. Her muscles all relaxed. That's when the seizure itself has ended. And so you can stop timing. There will be a recovery period afterwards where they become, where they come back to their baseline. But once they kind of go limp and their muscles relax, that's the seizure has ended. You want to get them on their side. Saliva, vomit potentially. You want to be able to protect their airway, really is what that's about. So getting them on their side is going to provide that opportunity. Cushioning their head is really important, and then removing anything that's going to constrict them or are in the way. And so that can mean things like glasses, something they're wearing, or it can mean you just have to push back the desks around them or get the other students back out of the way as well, just to give them the space they need for their body to go through their seizure. And of course, someone should always stay with them until they're fully aware. Next slide. There's a few different things we like to talk about certain situations in the school setting. One of them is if you have a student who's in a wheelchair. The first thing is to put the brakes of the wheelchair on, and most of the time you don't need to take them out of the wheelchair, especially if it's a wheelchair that's providing a lot of support for the students for them to be upright. That padding and that form, that sort of customized form that their wheelchair has will give them the protection they need. What you really need to worry about is being able to turn their head to the side and so that they can protect their airway and support their head. You can loosen the seatbelt, but you want to keep it fastened. And really, again, the tilt of the wheelchair and turning them to their head to the side are going to be the two key things. Next slide. Many of you might either be on buses when you are for part of your work, or if there's a field trip or something and you take a bus somewhere, there are protocols that we want to make sure we talk about with the situation on the bus. The key is to develop and know what your school's protocol is. If your bus system is a part of your school district, owned by your school district, there's going to be a protocol. If it's a contracted service, there's going to be a protocol. So just making sure that you're aware of what that protocol is should a medical emergency happen on the bus. The big key things that'll happen is they'll pull over. Usually someone has to radio into dispatch, and as they respond to the child that's having the seizure, what you want to make sure is, if it's this generalized tonic-clonic kind, you can actually use the back of the seat to give some support to the students, and that'll allow you to see their face as the seizure is happening. If it's not a convulsive seizure, you want to allow them to go through as much as they can without being restrained, their seizure, until it ends. But really the key is to know the protocol, follow your protocol, and if you have questions about what that protocol is, speaking to the person that's in charge of your bus drivers and your bus system. Next slide. Finally, we want to talk about water. Water is one of those situations where we want to make sure that we are getting them out of that situation and onto their side. You want to do whatever you can to get their head above water, obviously, and you want to be protecting their airway, getting them out of that water and then onto their side, and calling 911 or emergency services right away. Because as a non-medical person, you don't necessarily have the skills, or I don't have the skills, or many people don't, to actually deal with the potential for the water in their lungs. So it is important. Water is one of those safety things where a little bit of water can lead to drowning. And so if it's a situation where it's a pool or lake, getting them out is important, but we'll talk about water safety in just a minute in other areas. Next slide. There are times when you should call 911 right away. This is a list, and it probably is not exhaustive, but it's the most common times that we know you should call 911. First time seizures, let's say you have no recollection if the student has had a seizure before, or if they have epilepsy, that's a key time. If you cannot get a breathing pattern, and like if they've stopped breathing altogether, you want to make sure that longer that status situation for not or a single seizure is what the timing of the seizure is all about. So when you time a seizure, if it goes longer than 5 minutes, it is what is called status epilepticus, a medical word that just means medical emergency. And so you want to make sure to call 911 at that point. You can see the other ones we talked about: water, other health conditions, things like diabetes. If a student has diabetes, they might have a diabetic seizure, but that is something that you would want to call a 911 as well. Another health condition that is good to know is if a pregnant woman has a seizure, that is needs to have a 911 call right away as well. Oftentimes it has to do with blood pressure and can be detrimental for both mom and baby. And then of course, if you don't feel like you've learned everything and you're like, hey, something doesn't feel right in my gut, obviously you can call if you feel like you can't respond appropriately or you have any reservations. Next slide. We're going to briefly just talk about safety and epilepsy, and then SUDEP. There are things that we recommend about safety with epilepsy, and those things are, it's important to have a seizure action plan for students, and that really allows anybody who's going to be teaching or working with the student to know what to expect from their seizure, their epilepsy diagnosis, and their seizures in particular. We'll talk about probably seizure action plans in a bit, but what it does is it allows you as the person who is in the classroom with the student to know what types of seizures do they have, how long do they typically last, how should I respond. Those are some key safety things that can be put into that seizure action plan. We know that medication is, there's some safety around medication, taking medications, things from when you start a medication to and needing to record, what the side effects are and how it's working, to making sure medications are taken on time. Those are key as well. I'm going to skip on down and just let you know that a lot of these other safety things have to do with just making sure the conversation with the physician is had, so you know what are the restrictions, if any, for things like sports activities. And when it comes to driving, if any of you have teenage students that you work with, there are particular driving laws for each state in the United States. And in Minnesota, it's a 3-month revocation of your license if you have a seizure and have to get control again with a new treatment option. Next slide. Just to briefly tell you, SUDEP is one of those reasons that a person with epilepsy may die. It is rare. About 1 in 1,000 people with epilepsy will die from something related to a seizure. SUDEP is sort of like SIDS in that there's certain risk factors, but it's unexpected and they're otherwise healthy. And so being otherwise healthy, it just means that they don't have other things going on, but generally it happens as they go into sleep or come out of sleep. And there's a lot of research in this area right now because they're trying to figure out what is it with the heart rhythms and their breathing patterns and things like that. We do have this great resource from our national office called the SUDEP Institute if you're interested in more information. I'm going to turn it back over to Jamila now.
Thank you so much, Amy. All right, so we're gonna do another poll here. So let me just launch that with you all. All right. So do you have to call 911 if someone has a seizure in water? So the options are yes, no, and sometimes. So I'm going to give people some time here to answer. Right, the answers are coming in. It looks like there's a few more people that still need to put in their response, so I'm going to wait for them just a few more seconds here. The question is, do you have to call 911 if someone is having a seizure in water? Yes, no, or sometimes. All right, let me give it about 10 more seconds, maybe 5 more seconds, and then I'll end the poll here. All right, I will end the poll and share the results. So it looks like it's split down the middle almost, 50-50 with yes or sometimes. The answer is yes. So for the 43% of you that answered that, that's great. And the reason why we want to make sure we always call 911 when someone has a seizure in water is because we typically, in almost all these situations that this happen, do not have the medical technology, nor do some of us have the knowledge to help somebody who has just had a seizure in water. And as Amy said, it only takes a little bit of water to cause something really dangerous to happen. So you do always have to call 911 if somebody has a seizure in water. All right, let's move on here. So these are the treatment options I'm going to be going over today. So we have medication, brain surgeries, implanted devices, diet, and then we have medical cannabis. So we're going to start off with medications. Medicine is usually the first treatment option people start off with. Different medications help with different kinds of seizures, so it's not really transferable. A person who's using a medication for focal seizures can't take a medication for a generalized seizure. And then this statistic comes from the Epilepsy Foundation National as well. 7 out of 10 people living with epilepsy do find seizure control with a medication. Seizure control, again, can mean a lot of different things. And then you never want to stop or change your medication without talking to your doctor first. So 47% of patients find seizure control with their first medication, and then once you start to see is that number kind of dwindle after they try to start other medication options, and that's when people start to look at other therapy to try to help manage their seizures. Side effects vary by medication and individual, and these statistics, as well as the last bullet, comes from Epilepsy National as well. You may also have to administer rescue medication at your location. I would make sure that you make yourself aware of your internal protocol. If you're not sure if you can administer rescue medication, you might not be able to. If you're on the street or something and you know how to administer rescue medication for epilepsy, you don't have to have like a special license or certificate to do that. But when you're in a work setting or a school setting, something of that nature, future, you do want to check your internal protocol, because there might be some people who are specially trained to administer the rescue medication. Typically, this is going to be happening from the school nurse, and they're going to choose individuals or the entire school to train in this type of administration. When they do choose this, they want to make sure that they're delegating this out to people who want to do it and who are able to give that rescue medication. So just keep that in mind. If your school doesn't have a protocol, that might be something that you want to maybe put together, but you want to figure that out before you ever administer rescue medication. Typically, these are used for seizures that are clustered or more frequent. Maybe they're longer than they usually are. It's basically to stop that seizure from turning into an emergency. They're not used like daily medications. So rescue medications aren't something that individuals are taking necessarily every day, but to stop their seizure because there's an emergency. This information comes from epilepsy.com as well, and this is going to be different forms that this is going to be administered as rectal, so in the rectum or in the behind, buccally in between the gum and cheek area, and then nasally in the nose. So the best medication, the best rescue medication for somebody is going to be easy to use. It works quickly. It's safe with little or no side effects. It meets this individual's needs, and biggest of all, that it works well for this person. Brain surgery options may be looked at as well. Typically, people look at this form of therapy after a lot of other therapies have been gone through. If they have uncontrolled seizures, it can increase the risk for harm or physical injury, maybe accidental death ensued up. So this is definitely a time that a person may look at that brain surgery option, though I do hear a lot of medical professionals now go to this option a little bit faster than they would have in the past. And, you know, technology is getting better and better every day, so that can play a part in that. You do need a consultation with a physician to measure that efficacy and seeing if that is going to be an option that works for you. So some recovery points and outcomes is that most people are back to work and school in about 4 to 6 weeks. Changes in thinking, social activities, and emotions may take longer depending on the individual. They might need to take that anti-seizure medication after the brain surgery is over for some months. And then many people can achieve many of those new milestones that they may not have had previously. And this source also comes from epilepsy.com. There are implanted devices as well. So somebody would get a surgical procedure to get these implanted. We have the VNS, RNS, and DBS system. The VNS system is the vagal nerve stimulator, and then the RNS system is the responsive neural stimulation. And then DBS is deep brain stimulation, and these are really descriptive in their names. They all kind of do the same basic thing, but the VNS system and RNS system are a little bit more similar than the DBS system. DBS is a newer system, and it does have a little bit more capabilities. You usually won't see these devices in a person under the age of 12 years old. So with all of these devices, what happens is throughout the day, electrical signals are going to be sent to the brain to kind of help regulate that seizure activity. And if somebody does have a seizure, they kind of work in their own ways of trying to stop the seizure. The VNS system comes with a magnet with manufacturer and physician instruction, where the RNS and DBS systems also can send that extra electrical activity as needed as well. There are also a number of diets that a person with epilepsy may be on. You'll commonly see it in younger individuals or older adults. And that's because with these diets, they're very strict, the ketogenic diet being one of the strictest ones. So you do want to make sure that you are following it pretty strictly. And it's easier to follow a diet if someone is making those meals for you, or maybe you're not controlling it. You know, adults cheat on diets, and you really can't cheat on this diet. So that is why older adults and children are typically the ones that are on the ketogenic diet. So when we think of the keto diet, a lot of us might think of an advertisement we've seen on TV, or maybe something we've seen on Facebook or Instagram. It's one of those kind of popular ones right now. But it's not going to necessarily look the same way for somebody who has epilepsy. So it's a high fat, low carb diet, and there might be limits to fluids, or there may be some short fasting periods as well. So this is a really strict diet. For some people, it can help though, and may be combined with other options as well. So we have the standard American diet here. So it's about 60% of carbs and then 25% of fats. And if we look at what the keto diet looks like, as you can see, about 90% of that person's diet is going to be fat, and the carbs are reduced to 2 to 4%. And I wouldn't be surprised if that is actually a byproduct from the proteins and fats, but as you can see, there is a stark difference in between the two. We have other diets as well. These ones are not as common as the ketogenic diet. In fact, the ketogenic diet was made specifically for epilepsy over 100 years ago, but these ones also work for some people. We have the modified Atkins diet. It's a high fat diet, but it does allow more proteins and carbs than the keto diet, and it's a bit easier to maintain. We also have the low glycemic index diet. This one's based on portion sizes and not by weight. And this one is one of the more flexible meal options. So these all are typically used with another therapy, and they need to be guided and introduced by a physician. So you can't just decide that or tell a family that, hey, I think that this diet would work really well, and then they just start doing that. You may be able to say that you've learned something about it, and maybe they want to talk to their neurologist or their epileptologist, but definitely this isn't something that you would just venture into on your own. There's also medical cannabis as well, and the easy thing about this one is that it is not allowed on school grounds or school vehicles in the state of Minnesota. If you get any questions about using CBD products in school, that is not allowed either. And these are going to be in pill, liquid, or oil form. There is an FDA approved cannabidiol that is allowed on school settings. You get it from a pharmacist, and it's different from the medical cannabis program, but that is the only product related to that that is allowed on school grounds. And I'm going to turn this over to Amy now.
All right, we're going to wrap some things up and talk a little bit about how to support students with epilepsy now. As you think about the students that you know of in your school who have epilepsy, there's some things to keep in mind. Staying calm during the seizure, we've talked through that, but being supportive of the whole student and their whole experience. Many of the students might have a seizure action plan. If they don't, we have free templates on our website that you can certainly print and give to parents. It's great to have an action plan because it allows the parents to communicate with you the knowledge of their child's seizures. It also has a portion where the doctor fills it out and any medical sort of information that you might need to know. Those should always be included if the child also has an IEP or a 504. And we recommend that at any meeting, whether it's a yearly meeting or a 3-year evaluation of the IEP, that seizure action plan is reviewed as well, because oftentimes as someone progresses through their epilepsy or as a child grows, they might have changes to medication or control. Knowing what the potential side effects are for the child's medications, this hopefully will come from the parents or the caregivers or guardians, that, just asking the questions like, are there anything that we should know are side effects for the child when they're taking this medication? Kids with epilepsy do tend to have a lower self-esteem, and so really as much as you can encourage them to interact positively with their peers, that is a great step too. Next slide. When we talk about impacts on learning, there's lots of different learning challenges that can occur. Oftentimes, one of the reasons for the impact on their learning can be related to how frequently they're having the seizures, you know, their level of control, maybe where in their brain the seizures are happening. That might be a portion of their brain that impedes their ability to learn. The types of seizures they are having and their medication side effects sometimes will make them more sleepy. They'll make them have memory issues, things like that, where they would probably, you might see some impacts on their learning. And also the age of the onset of their seizures can have an impact on learning as well. When you look at what's helpful, like again, we said the seizure action plan is always a great thing. Communication and more communication is what is really important with parents and guardians. Sometimes they might even go through neuropsychological testing to see where they're sitting with their seizures as it relates to their mood and their ability to do different tasks and functions. Next slide. I'm going to briefly tell you a little bit about 3 different models of learning considerations that we recommend when you're thinking about your students that have epilepsy. As the pandemic happened and last spring ended very strangely for all schools, we took a look at what was being asked of the schools from the governor and took those 3 models and thought through and put together some recommendations for our families of things that they might want to consider in each of these models. For the in-person learning model, really about seizure control and triggers, you know, finding out from the parents, has anything changed since you've been at home? You might have parents that are going to choose to have their child be distance learners because maybe they have a couple of other medical things that they're just really concerned for their safety and they are more susceptible to contracting COVID. Just so you know, if a child has an epilepsy diagnosis or anyone, and there's no other health concerns, they are at no higher risk of contracting COVID or having a more severe form of anybody else. And so really what we know is that the children that are going to be more impacted is those that have multiple medical things going on. Maybe they have an immune system co-diagnosis, or they're taking a medication that causes them to have a lower immune system. You want to just make sure in those in-person learning models that you know whether they'll have to wear that mask or not, if they have a special exception for them, and then that could probably and should probably be put in their IEP or 504. Next slide. When we talk about distance learning, just a couple things to keep in mind. If they have that trigger of increased screen time, that might mean that they have to do some adapting. One of the biggest things about distance learning that we think about is what's the impact socially and mentally on the child, right? And so maybe there may be some things that if they are not able to be in the same space as their friends and their classmates, that might be something to think about as well. Next slide. And in the hybrid model, things about such as transitions. How does the student transition? Is it too challenging for them to go, you know, from distance to in-person in the same week? It might mean that parents will request for their child to be in person all of the time, or they might choose to be distance all of the time just because transitions are hard. Because what can happen is different things like disruption, different start times, different stop times, you know, maybe the bus is coming at different times. All of those things might be difficult with medication regimens and things like that. One of the biggest things is to communicate, have a way to talk to the parent, whether it's a journal or notebook or things like that. And oftentimes you might want to consider if they receive support services such as physical, occupation, or speech therapy, when they are actually in this classroom or in school, are those more important? Should they really get those services on the days where they're in school versus when they're distantly learning from home? Next slide. There are lots of resources. I'm not going to say much about these, but you will receive this information afterwards. So there's lots of different resources related to the models of learning. Next slide. And we do have an information service person who works 40 hours a week answering questions. She can provide one-on-one support, whether it's email or phone call. Her name is Debbie Leone, and her contact information is here on a variety of epilepsy-related topics. Back to Jamila to finish us out.
All right, so we are getting to the end of this PowerPoint, so please continue to enter in your questions here as I go through these next slides. Um, I do want to note that I do have my contact information here, that you can feel free to contact me if you have any questions. An evaluation will be sent with a follow-up email coming shortly within the next few days. So look out for that. And I also just want to go through the references to just have that be picked up on the recording here. And it looks like we're getting close to the end. So I do want to answer the questions that we do have now. So let me open that up and see. All right, so one question that I have here that I think I'm going to give to Amy is, can staff respond to seizures while there are social distancing protocols?
Absolutely. I think that as you look at what your schools put into place for COVID and the social distancing, I know that, it might mean, well, it will mean gloving and a face mask, probably even a shield. Maybe your school is able to provide a disposable gown, things like that. Just ask your school nurse what the protocol is, but yes, you should still be responding to those seizures appropriately.
All right, thank you, Amy. There's another question here. Is cloth face mask considered personal protective equipment, so PPE? So cloth face masks technically are not PPE. And so you do want to make sure that you are checking with your school district or your school to make sure that you know how those are going to be provided for you or to you, but that is not considered PPE. And then it is 5 o'clock here, so if we didn't get to your question, we will get back to you with a follow-up email. If there are any other lingering questions that you have, or you maybe didn't want to share it in front of everyone else, please feel free to reach out to me here. But I do want to thank everyone who has joined us tonight, and I hope that you all have a wonderful evening and have learned a thing or two. Thank you so much, and thank you, Amy.